it's my pleasure to introduce Gary Schwitzer. He's the health news review guru. Gary is a journalist. He has been a professor, and he has many, many years of experience advancing the field of reporting research and science with great quality. And he has been one of the pioneers in disseminating the concept of the health news review criteria and how to apply this criteria to some of the stories that you developed to improve that quality and fidelity in reporting. So without further ado, please, Gary, join us, and he's going to be guiding us through the rest of today in several activities. You have your headset?
I do.
Okay,
yes.
Thank you.
Am I working? I am, good. I'll only start here so that if anyone is short, they can see me from the back of the room, but then I'm going to come down to our community level. So, yes, it's 40 years this year that I have been specializing in healthcare journalism, and somewhat similar to Deshira, I worked for 15 years in television news, and at the end was the head of the medical news unit at CNN in Atlanta. But that's another story. So for the past now almost 8 years, I've been publishing this website called healthnewsreview.org that I'm so grateful that the National Cancer Institute has sort of taken our model and tried to adopt it to this forum. So what you're hearing, while it is based on an analysis of US healthcare journalism, I heard all of your comments. I appreciate all of your comments. They are exactly the same, maybe more in certain areas, maybe a little less in other areas than what we see in the US. But we have shared this through these NCI workshops in Brazil, in Argentina, in Mexico, in China. I've given workshops similar to this one in Great Britain, in Germany, in Barcelona. So I try to include in this talk the perspectives that we've heard and learned from around the country, and your input will make us smarter as we move forward as well. So this is a term that a European coined, and it's a combination of information intoxication. So they're calling it infoxication. And I think that, unfortunately, in an attempt to do good, we often intoxicate or infoxicate the public with an overload of information, perhaps not all of which is newsworthy. These are the 10 criteria that our project, our website, applies every day, except when I'm traveling here today, although there are people back at home still working on this, to the review of stories that include claims of how good something is, how well it works, how safe it is in any intervention, a treatment, test, product, or procedure. So we look at and we evaluate the story. Did the story explain the cost? Did the story explain how large is the potential benefit and how large are the potential harms? This is often a matter of how small is the potential benefit and how large are the potential harms. How strong is the evidence? Was this a single case study? Was this a mouse study? Or was this a result from a 3,000-person, 3-year randomized clinical trial? Is the condition exaggerated? Are we treating toenail fungus as if it is or baldness or dandruff as if it is something that must be treated? But also more seriously, in heart disease and cancer, are we treating test scores and numbers as if they are the outcomes that we should necessarily focus on? We'll talk more about this. Is this really a new approach, or is it old fish wrapped in new newspaper? Is it available? Or is this an early stage trial that we make it sound as if it's available at our pharmacy? In talking about the new, do we talk about the old and the existing alternative options that are, by definition, more tried and true and have a longer track record? Who's promoting this? Does the story have time to include more than a single source, something we've already talked about? And do these sources have any financial conflict of interest? These are 10 things that we think stories aimed at consumers about new stuff in healthcare need to address. It may not be a perfect list, it's our list, sort of our stake in the ground that this is a starting point to improve healthcare journalism and improve the public dialogue about healthcare. So I told you these are the types of stories that we review, which is the majority of stories that we see. I should explain that if you go to our website, and I hope someday you do go to our website, you'll really see two parts of it. This is the part that does what I've just talked about. It's more systematic, more objective, more criteria-driven, where we apply these 10 criteria to the story, and then we give it a satisfactory or an unsatisfactory score, and we explain why. And we've done this now almost 1,900 times in the past 7 years. But then in addition to that, we have a blog called the Health News Watchdog on the same site. And in the nature of most blogs, it is not as objective. It's more subjective, more opinionated, edgier. And so we talk about things like how oncologists too, not just journalists, could improve their understanding of math, and how advertising and marketing comes into play many times. So through this blog, we comment many times about more than journalism, but get into issues of public relations, advertising, and marketing messages that also affect the public dialogue. And then also things like, this is a case of what we would call disease mongering, perhaps in the attempt to promote and sell products where if you look hard enough, you can find marketing claims that say that testosterone should be used almost anywhere in the body for just about anything. So here is the report card at a very high level, very briefly, after looking at more than 1,800 stories for 7 years. And it's not a very good report card. That 70% of these stories get an unsatisfactory score on discussing costs, on quantifying benefits, on quantifying harms, and on evaluating the quality of the evidence. Those are probably the most important of our 10 criteria, and this picture summarizes that in general then, we see stories over and over and over, 70% of almost 1,900, that exaggerate or emphasize benefits while ignoring or minimizing potential harms. To most audiences, we wrap this up and say, that suggests that news stories are giving the public a kid in the candy store picture of US healthcare, at least, where 70% of the time they make things look terrific, risk-free, and without a price tag. And think about that. If we're doing our job as journalists, if we do make a difference, our project would suggest that 70% of the time we're not doing a very good job in truly informing and educating the public. And our goal, we sort of talk about the ABCs of healthcare journalism, to be accurate, balanced, and complete, and 70% of the time, at least, we don't get there. Here's an example. This is my former network, but I worked there so long ago, 20 years, that it really bears no connection to current state of affairs there. This was a story based on a news release from a leading U.S. cancer center, MD Anderson in Houston. But it's an example of how even an international leader like CNN bases their story simply on a news release. This was an announcement by a cancer center that they were setting a new goal. And it wasn't based on any new evidence. In fact, they said that their goal was based on everything that had been learned up to date in cancer research. So it's really something that almost any hospital or medical center could have made this announcement. Yet here we have a network calling it a breakthrough. Well, nothing had been done yet. It was a news release and an announcement of a hope, a dream, a goal. And here we have Sanjay Gupta saying it was a cure within reach. It was no more within reach after this news release than it was before the news release. And yet, you couldn't buy this kind of airtime, and it was given away free. It was not an evidence-based promotion. What they didn't report was this, that at that medical center, and this is a case, well, there was Lenora gave the introductory talk this morning and said, especially Gary's talks don't reflect, his opinions don't reflect the opinion of the, well, this isn't my opinion, this is a fact. That medical center has had major issues of resignations, questions about conflict of interest, and fraud probes of the very program that made that announcement. Why wasn't that in the story? Well, it's not likely to be in the story when you enter into an exclusive arrangement where I'll say, Genevieve, I will share this only with you. Well, you're probably not going to tell the dirt on me when we enter into that kind of a relationship. The following slides just run through at a very high level some of the common flaws that we see in the stories that we review, where there is too much stenography. I say it, you write it down, you report it. You just simply become my mouthpiece to the public, instead of independent vetting of claims. So, we tend to glorify big names and big journals. I don't know if I need to say this to this crowd because I don't know you all, but publication in a big name medical journal is not something that is cast in stone and brought down from the mountaintop to be given to the people. It is, I often say, science is like a winding stream, and we journalists are like a little child who runs up to the stream, dips our toe in, and then runs back and files the story, never seeing that the stream continues downstream, taking different turns and directions with different turbulence that we're not aware of because we just dipped our toe there in today's journal report. We report on many things from journals that are not ready for prime time. Believe me, I'm a huge believer in public access to research information. I support the open access movement in publication of journals in that way. But if we're going to play this game of accessing information that way, we need to know the journals are not there for immediate public dialogue without some filtering, without some help. They are meant to be conversations among scientists. If we don't understand that landscape, we shouldn't be playing in this game. This is the point that I was just making. If you don't know that landscape, you don't know that among the things that are being published are things that increasingly are being retracted, or we find out more about research fraud, or fabrication, or falsification of data. I'm not saying this is in the majority of cases by any means, but if you're not aware of this, you can tend to glorify and deify things that are not going to pan out in the long run. there is a huge amount of unpublished data that affects the overall picture of what we should be hearing. So the British Medical Journal had a special edition just on the problem and the extent of unpublished data that none of us is aware of. And the ghostwriting of journal articles, where often industry, often drug companies, will pay a writer to make findings look better than what the data actually showed. If we're not aware of this landscape, we might not be giving a very good picture to our audience. So continued flaws that we see, the failure to evaluate what is really very weak science. What one writer, actually a Peruvian, Victor Montori, who's at the Mayo Clinic now, called idolatry of the surrogate. So not understanding or simply not reporting that surrogate outcomes, like tumor shrinkage, may not mean that people lived longer or lived better. This is an example of a surrogate outcome or a surrogate marker or a surrogate endpoint. Are these the outcomes that we really should be talking with our audiences about? Or are they, did people live longer and live better? Which is more important? We often see reckless extrapolation. So going from a mouse study to extrapolating as if this will have a definite impact on people when we simply don't know that. A lack of awareness of conflicts of interest and other ethical issues. Going soft on business stories if they represent industry in our communities. I happen to live in the Minneapolis-St. Paul area in Minnesota, and the newspaper there, I've been writing a series of articles about how they go pretty easy on some of the big medical device companies that are based in Minneapolis. Here's an example of a story, and this is also somewhat similar. So this is an excellent public radio statewide network in Minnesota, and they were reporting on the Mayo Clinic, which is in Minnesota, and reporting on a prostate cancer scan that could help Mayo Clinic doctors with early detection. And in that story, they said, the scan allows men with cancer to get treatment that is both faster and potentially more effective than current treatments. Well, that's Mayo Clinic, and that sounds pretty impressive. But stories about tests, whether it's this test or any one, should include information about sensitivity and specificity. How many people know what I'm talking about? Then I'll go slow. So sensitivity shows how many of the positive tests really are positive. And specificity tells you how many of the tests that say you don't have a problem, you really don't have a problem. That's how we get at accuracy of a new test. What this story didn't report was that past studies of that approach that they said was so fast and so good had a false positive rate of anywhere between 15 and almost 50%. So think about what that means. And one report out of Mayo itself reported an 11% false negative rate. People's lives are affected by false positive and false negative test results. So it felt to us like that story glorified this approach without telling the real meat and potatoes issues that people needed. So we thought, shouldn't that be reported right alongside that statement that men got treatment faster and potentially more effective? Maybe we should talk about the people who were misled by what the test suggested. We can all, I hope all of your minds are racing about any sort of test that you've reported on and whether you've reported on sensitivity and specificity. In reporting about new devices, And we may not have any of these devices. This is a drawing of proton beam, which the US leads the world in these. There's probably 13 to 15 of these devices that are so big, they require a linear accelerator to be sunk in the ground the size of a football field, a soccer field. $200 to $300 million to install one of these devices. And many experts would say, we don't have the evidence that this approach is any better than what we're already doing. But it is new, and it is expensive, and it is labeled as exciting. It definitely has its place for some cancers like small pediatric brain tumors that are hard to get at safely. But as so often happens, prostate issues seem to take the forefront, and this is being used increasingly on prostate cancer, and that's where many doctors say, we don't have the evidence that it's any better than what we're already doing for prostate cancer. Another approach, also often done in prostate cancer, is robotic surgery, the Da Vinci robotic surgery. It's claimed to be less invasive, therefore safer, and there have been publications that raise questions about whether the outcomes really are any better. Does anyone know, do we have any proton beam in Caribbean or Latin American countries? How about robotic surgery? We probably have robotics. Okay, yeah, okay. Well, I hope you ask questions about the robot. Okay, another big area where we use the wrong language to describe observational studies. So observational studies, I ask table 5 to keep a diary of their diet and write down everything they've eaten for 10 years. And then we come back and see how many of them developed breast cancer. And then we report that these people with these dietary patterns were associated with this rate of breast cancer. In that kind of a study, which is valid, we simply cannot prove cause and effect. We can't prove that anything about their diet had anything to do with their breast cancer or anything. It does not say that study is not important. This is the journalism issue, but it often is the researcher issue as well. This often gets communicated as that it caused a higher rate of breast cancer or it lowered breast cancer. We don't know that. All you can accurately say is it was statistically associated with a higher rate or a lower rate. And if that is too many words for you or for your editor, who raised the editor thing earlier, then maybe you should suggest to your editor that we shouldn't be doing a story like this because we will cause harm. We mislead when we miscommunicate these issues. Here's one. This is a story I would have liked to have given the finger to. So it was a story that suggested that how long a man's fingers are relates to his prostate cancer risk, okay? A really interesting finding, but can we prove cause and effect from this? No. And yet, the story said this could be used as a simple test for prostate cancer risk. No, it cannot. So of our ABCs of accuracy, balance, and completeness, we don't even get past accuracy. That's simply inaccurate. Based on what? Well, these men were, read this, these men were shown pictures of different finger length patterns. So Gary, look at these pictures, and your fingers look like which of these pictures? Okay, so there's already, I might make a mistake in identifying my fingers with the pictures, so there's a bias built in. And then men whose index and ring fingers were the same length, which was about 20% of those studied, had a similar prostate cancer risk, but men whose index fingers were longer than their ring finger were why do we waste people's time with this under the headline that this is a cause and effect relationship, which it is not. Association does not equal causation. So just because your rooster crows every morning when the sun comes up does not mean that the rooster made the sun come up, does it? So we laugh at that, but similarly, just because this group ate a lower beef diet and had a lower breast cancer risk does not mean that the rooster made the sun come up, that the lower diet resulted in the lower breast. It's a very interesting finding. It does not prove cause and effect. We should not miscommunicate that. So remember my rooster. We often exaggerate the effect size. So 2 of our 10 criteria. Did you quantify harms and did you quantify benefits? We hold the bar very high. If the story quantified, used numbers, but did so in relative risk figures, which I'll explain, not absolute risk reduction figures, we give it an unsatisfactory. So, there are 2 ways of looking at an effect size. The one way, which is not good enough in our eyes, relative risk, makes the effect size seem larger. But the other way, the absolute risk reduction, makes the effect size seem smaller, and we think it is more meaningful to a lay audience. So here's an example. This was a New York Times story from a couple of years ago. Drugs to deter some cancers are not taken. And the drug in question here was Nolvadex or tamoxifen. And the story said that it was effective in reducing breast cancer risk by 50%. This isn't an absolute statement, but it's a suggestion. Anytime you hear of an effect size of 30, 40, 50%, you better start asking yourself, 30, 40, 50% of what? And am I getting relative risk figures or absolute? So in this case, this is what the drug company advertised. For the first time, there's a clinically proven way for many women at high risk of developing breast cancer to significantly reduce that risk. The proof? Well, in a big study, women who took the drug had 48% fewer breast cancers than women taking sugar pills or a placebo. So, 48% fewer breast cancer cases. This is where I ask you to think 48% of what? And I should have said, I give a credit at the end. These slides are borrowed from my friends Steve Woloshin and Lisa Schwartz of Dartmouth Medical School in New Hampshire, who are very good in educating researchers and journalists in how to communicate. And they say that 48% is like having a coupon at an extremely fancy store, okay? But it's only good on selected items. So a big number, but it's only good on selected items. Well, what if the selected items were like television sets or washing machines? What if it was only good for things like pieces of candy? If it were the big items, you would save hundreds of dollars. If it's the little items, you would save pennies. 48% of what matters? You've got to know the regular price. You need to know the absolute risk reduction. So, in this case, what is that 48% off coupon really worth? Well, the breast cancer risk, the chance of getting breast cancer, you want to look at what was it with placebo, what was it with Nolvadex or tamoxifen, and how much did you save? Well, the chance of getting breast cancer over 6 years in the placebo group was a little more than 3%. That's the regular price, the base rate, the absolute risk in the placebo group, or the event rate, they might call it. In Nolvadex, the chance of getting breast cancer was reduced to a little less than 2%. That's the sales price. So what is the effect of Nolvadex? How good is that sale? What is that coupon worth to you? Well, how much do you save? You take the regular price, 3.3%, minus the sales price, 1.7, and you get a 1.6% difference. I thought we heard 48%. Well, this is the absolute risk reduction. So, a way of saying this is the chance of getting breast cancer over 6 years with this drug was about 2 percentage points lower than with placebo. Now, another way of looking at how good is that sale then, the relative risk is the chance of the outcome from the intervention, Nolvadex, over the chance of the outcome from the control, the placebo. So 1.7% divided by 3.3% is 0.52. And this is how you get at relative risk. And don't let your minds go numb with all of this. I'm just painting the picture for you. Although some of you are probably good enough to be here already to show you this is how they got to that 48% figure. But which is more meaningful to you if you're a woman with breast cancer? The 48% off, or the fact that 2%, there was a 2% difference, 2 out of 100 women difference benefited. So at 6 years, the chance of breast cancer for women taking Nolvadex was 48% lower only than that of women taking the placebo. Oh, I'm sorry that my formatting got messed up here. This is what happens when you do a PowerPoint on a Macintosh and you show it probably on a PC. But this is 48% off. So this is the relative risk figure on the left, and this is the absolute figure on the right, showing you what that coupon is really worth. 2 ways of saying the same thing. Neither inaccurate. One, we believe, far more helpful to a lay audience. One feels big, one feels small. How you say it, the framing, really matters. So, you know what? I'm going to fly through these. How am I on time, Genevieve? This is getting a little detailed here. These will be in your on your jump drive. Actually, this is really important. We should slow down and look at this, because these are 3 different examples that I think educate. So another way of looking at the relative versus absolute risk reduction. The chance of death at 1 year, placebo versus drug. The relative risk is what percentage off. The absolute risk, again, is the true savings that you would have. So in this case, if the chance of death at 1 year was 30% on the sugar pill and 10% on the drug you really care about, the relative risk would be, we're doing the math for you here, 67%. That's pretty impressive. The absolute risk reduction would be 20%, 30 minus 10. A little bit less impressive. Let's look at a different scenario. What if it is not 30 and 10, but 3% chance of death at a year on the sugar pill, 1% on tamoxifen, or any drug here? The relative risk reduction would still be the same, that impressive 67%. But now what would your absolute risk reduction be? Very good, 2. Same relative risk. Now our absolute risk dropping even lower. Let's go lower still. 0.003% chance of death in a year on placebo to 0.001% on the drug. The relative risk is the same. The absolute risk reduction is minuscule, tiny, mouse print. I think this is really a worthwhile example. So let's go back to how the drug company advertised this in a magazine ad, the 48% fewer breast cancers. So that was in talking about the benefit. What did they say about the harm? They said Nolvadex isn't for every woman. In the study, women taking it were 2 to 3 times more likely to develop uterine cancer or blood clots in the lungs and legs, although each occurred in less than 1% of women. 2 to 3 times more likely, those conditions, although each occurred in less than 1% of women. It's interesting that when we talk about the benefit, we use the more impressive relative risk reduction figures, but when we talk about the harm, we try to minimize the effect of the harm and use the absolute risk reduction figures. This doesn't just happen in ads. We should count, and I'm not counting, and I should, the number of journal articles that do the same thing. The investigator wants his or her work to look more impressive, and so we'll see some numbers in relative risk figures and some in absolute. We need to sharpen our eyes to find these. So, strokes and cataracts were more common with Nolvadex. Most women experience some level of hot flashes and vaginal discharge. This doesn't tell you anything about how often this occurred, does it? No numbers. So we should present benefits and harms the same way. So in this case, it would not, if you're going to play the relative risk game on telling benefits, then tell the relative risk game in telling harms, and your ad would say that the harms happen 210% more times. I'm not holding my breath to see if we see that ad. 210% more uterine cancer and potentially life-threatening blood clots. So, that 6-year chance of the blood clot in the leg or in the lungs, in the placebo, let's say, is 0.5%. In Nolvadex was 1%, almost like economic inflation. We doubled the price here. So this is the overall breakdown of benefits and harms that might be more helpful to people. That, the 3.3 versus the 1.7, absolute risk reduction, and the absolute numbers on how often the harms occurred. The net effect for every 1,000 women is, this is the story the way it could be told. For 1,000 women, 16 fewer got breast cancer, 5 more got serious blood clots, 6 more get uterine cancer. I think women could make a more informed decision if we broke it down for them in this way. So, back to our website. We try to help journalists. Our site is not about simply criticizing. We try to reach out and help. We try to come to workshops like this. We have an entire toolkit on our site that has brief primers that explain important concepts in understanding studies. These are just some of them. You can find these on our website on your own later. This was an example. This is where Victor Montori of Mayo wrote this article, The Idolatry of the Surrogate, in the BMJ. And in cancer, we've seen a major debate over the use of the drug Avastin in breast cancer. And this was a perspective piece in the New England Journal that looked at the term progression-free survival. How many people are familiar with that term? Progression-free survival. That's the length of time during and after the treatment of cancer that a woman lives with the disease without it getting any worse. Progression-free survival. She lives and it doesn't get any worse. But is that really the most important outcome, or is it overall survival? how many women live longer. And this was at the root of a major scientific debate over this drug. And this issue wasn't communicated very well by journalists, at least in the US. We had a lot of discussion earlier today about how do we find the right experts and how do we find the best experts in our country. Well, I can't help you right now with that, but on our site for US journalists, we list the names of about 100 experts who have sworn to us that they have no financial conflict of interest with industry and that they are willing to work with journalists on deadline to the extent that they can. So on the public site, all you'll see is the name and where they work. But if a journalist writes to us and proves to us by sending us some articles that they are a journalist, we'll send them an Excel spreadsheet that has phone numbers, email addresses, often cell phone numbers and home email addresses or home telephone numbers of more than 100 such industry independent experts. This is a guide that I wrote for the Association of Healthcare Journalists, which I would encourage you, if you work in this field all the time, I would encourage you to join. I believe, while this is a US-based organization, there are more than 1,100 members from, I think, 15 countries, and I believe that international membership is something like $30 a year. And I can almost guarantee you, you'd get your money's worth from this if you did nothing more than lurk on the email listserv of journalists every day. I do, and I know if I checked my email right now, there are messages coming in all day long, every day, from journalists who are on deadline, and they write to the membership saying, I need help. I'm not getting any answers. I don't know where to go. And within hours, they get responses from often some of the top journalists who are members of this organization. So that's where I say, if you got nothing else from your membership, that would be worth your money. But you'd also get this book for free, which I wrote, which is about, it's only about 70 pages long. It's not perfect, but it's not a bad overview of how to do a better job in reporting on studies. If you don't know about this guy's name, he's a Greek, now living in the US, works at Stanford now, John Ioannidis. He writes over and over. He is a prolific author, and he's probably the leader from within the research community criticizing, or really just holding up a mirror to researchers and to the public that much of what we publish is really not that good, or there are many flaws in it. So I'm not going to try to tell his story here, but write down his name, Ioannidis, and a simple Google search will make you a lot smarter if you read some of what he's written. Journals, as I've said, are complicit. They are part of the problem in miscommunicating research findings. And the journals themselves are starting to communicate this. So here in the Journal of the American College of Cardiology, editors of this group of journals recently stated inappropriate word choice to describe results can lead to scientific inaccuracy. If they're getting it wrong, you're going to get it wrong, unless you're really sharp. And I'll bet you are. Here's the American Journal of Obstetrics and Gynecology, just recently, asking, are we making a mountain out of a molehill? A call to appropriate interpretation of clinical trials and population-based studies. A commentary in the Archives of Pediatric and Adolescent Medicine entitled Spin and Boasting in Research Articles. So if you follow research, and we're eavesdropping on this conversation among researchers, you will hear in that eavesdrop conversation, they are admitting to themselves, we need to do a better job. Well, so do we in this house of journalism. In the Annals of Oncology, this was really interesting, and I pointed this out because this was cancer specific recently, just in January. Bias in reporting on endpoints of how well something works and how harmful it is in randomized clinical trials for women with breast cancer. So here are randomized clinical trials that are at the top of the pyramid, the hierarchy of evidence, the best form of evidence, and these authors are reporting on bias. Even in these studies, Reuters reported on that, saying doctors who rely on studies published in top journals for guidance about how to treat women with breast cancer may not be getting the most accurate information. This shouldn't be shocking to you if you are well-versed in the literature. But if you're hearing this for the first time, please open your eyes and learn from this. We need to get better in applying scrutiny. What those authors pointed out was that investigators go overboard to make their studies look positive. Remember what I just told you? There are researchers who report some things to look better by using relative risk. This is an example of it. In 2/3 of the studies that they looked at, that meant they didn't list serious side effects in the abstract. Well, how many of you on deadline, you don't have any help in your newsroom, and you just say, I cannot read this entire study. I only have time to read that abstract. How many doctors, Marcia, only have time to read the abstract because they have so much, and you're not even going to hear side effects in 2/3 of the studies. And in 1/3 of the studies, if the treatment didn't work as they hoped, the researchers reported on something else. Well, we said we were going to do this. That didn't really work, but here we want you to focus on this because this looked better. I'm not making this up. This was researchers writing about researchers. And then we have journal articles about news releases and about news coverage. So here's the food chain. Bad studies, maybe from well-intentioned researchers, that are written up poorly in news releases, that are written up even more poorly in news coverage. And what about our poor readers at home? Where have we left them? Positive spin, does everyone know what I mean by spin? Making something look better than it really is. Was found in about half of the news releases and the stories, and the main factor associated with spin in the news release was spin in the journal abstract itself. In other words, a direct link in the food chain from published study to the, from the published study to the news release to the news story. We have a public misunderstanding of cancer risk. Studies have shown consistently that people overestimate their own risk of cancer. We can help them. We can do a better job in this area. And then other studies show people overestimate risk factors that have not been proven, and they underestimate risk factors that are well established. We can help them do a better job with this. This was a study in the journal IRB, which is Investigational Review Board, Ethics in Human Research. Unrealistic optimism in early phase cancer trials. People tended to overestimate the benefits of the trial they were enrolled in and underestimate the risks. Remember my scale of justice slide at the very beginning of my talk? I said that stories tend to exaggerate or emphasize benefits and minimize or ignore harms. This part of the food chain does the same thing. So in our work, we try to hold up a mirror to journalists and say, ask yourselves, if you cover this kind of stuff about new stuff, new treatments, tests, products, and procedures, do you think you might be reporting too much? Are you part of the infoxication of the public? If so, have you spoken with your editors? Well, I know you have, because you brought it up. Do you want our help? If they'll pay my way, I'll come. But point them to our site, that this is a well-meaning 8-year-old, 1,900-story effort that takes no advertising, no financial conflict of interest, simply trying to help. Mr. Editor, Mrs. Editor, if you don't see it, could you please listen to them? We've had journalists do that with success. And if you don't think you report too much of this kind of stuff, what kind of grades do you think you would get if we applied our 10 criteria? Later today, we're going to apply those 10 criteria, all of us, with some real examples. And maybe you'd be able to answer that more honestly after we do that. So I want to thank Woloshin and Schwartz from Dartmouth for some of their slides. This is my email. I have to leave tomorrow, so I won't be here for that session about the challenges that you all face, but I'm here all day. You're going to be so sick of me by the end of the day because I give 2 more talks and I lead 1 workshop. But please use me while I'm here, and I'll be here tonight eating the good food in the garden as well. So thank you for your interest. We have time for some questions.
Thank you so much, and as you know, we're going to continue the session with Gary.
Right away? Okay. So, for about 20 minutes or so here, I was going to go through our 10 criteria with you and explain to you how we apply them. So we'll go into a little bit more depth about what these criteria are, why we chose them, and how we apply them when we grade the stories. And then after that, each table will receive a story, and maybe if we have time, 2 stories, to review, and you will each individually read the story, make up your own mind about what the grades should be, and then as a table you will discuss, and then we will reconvene as a group, and I will have someone from each table talk about what you thought about the story and about the process. Okay? Any questions about that? And Nina, I don't think the score sheets are in the folder, just so you know. Okay. Okay.
Jacqueline.
I'm sorry.
I'm not sure.
Okay, nothing right now, though. Don't need anything. Okay, so, you know, I did not explain, and I should. These 10 criteria didn't just come out of thin air. There's a reason for all 10 of them. And each of the 10 is based on either a pioneering study that appeared in the New England Journal of Medicine in the year 2000 that was the primary author was an Australian journalist whom I respect. I think he's one of the top health, medical, and science journalists in the world. His name is Ray Moynihan, and he co-authored it with some physicians at medical centers around the U.S., and the study was looking at news coverage of 3 leading drugs, 3 of the most commonly prescribed drugs, and they reported on what was in those stories and what was not in those stories. And that inspired me. Then, shortly after that, I wrote some people would call it the Code of Ethics. We called it the Statement of Principles for this Association of Healthcare Journalists that I told you about earlier. And I wrote this Statement of Principles, and we came up with some more ideas of things that we thought were important for health journalism. So each of these 10 criteria is based either on that New England Journal of Medicine article I mentioned or on the Statement of Principles of the Association of Healthcare Journalists, which the board of directors of that organization signed off on and blessed. So, come on, wake up here. I tried to forward it. Oh, is that off? It's off. Okay, thank you. So the first criterion on costs, maybe we worry more about that in the U.S. because the U.S. spends a greater percentage of the gross domestic product on healthcare than any other country on the face of the earth, twice as much as almost any other country, and yet we come in something like 37th in the world in infant mortality. You know, if the US came in 37th in the world in the Olympic medals race, there would be rioting in the streets. But we spend all this money and still can't even take care of moms and babies as well as some poor countries. And so costs to us, and we also don't have any form of national health insurance. We spend 17% of the gross domestic product on health care, and we leave 17% of our neighbors uninsured. Sometimes it's very difficult to be an American and face those facts. So costs matter. So when we look at stories, this is something we see a lot. The cost is much lower than. Well, just as with harms and benefits, we expect you to quantify that. What does much lower mean? What is that cost? How much lower? We realize it might be difficult to describe the costs of a new experimental approach. It's just being researched right now. It's not on the market. How can we talk about costs? But we would ask journalists, can you at least talk about the costs of existing alternatives? Is this new approach comparable to any other approaches that are already being used whose costs you do know? We always believe with our review team, if it's not too early for you to talk about how wonderful this is, it's not too early to talk about what potential costs are. In the US, there was a study a year or so ago that reported that perhaps as many as 1 in 5 people do not take the drugs that a doctor prescribes for them because they can't pay for them. That is another great indicator of why cost information is important for us as journalists and communicators. And yet, as I told you, 70% of the almost 1,900 stories we've reviewed fail to adequately discuss costs. And I think we're being very lenient in the way we grade these. If there's any discussion of costs, in fact, if the story even said, this is so early and so experimental that it's impossible to discuss costs, we'll give it a satisfactory grade because they at least acknowledged that cost is an issue. So this is what I'm going to do with each of the 10 criteria. I'm just going to give you some examples about how we apply them. So, benefits. As we talked about, risk reduction should be given in which kind of terms? Relative or absolute? Absolute. There's nothing wrong with giving both relative and absolute. In our minds, there is something wrong with giving only relative, nothing wrong with giving only absolute. It is just like with the cost issue. If you say that it is much lower, that's not good enough. It is insufficient to be so vague as to say that something significantly increased or significantly decreased risk. What does that mean? How was it measured? Be specific. We can educate and improve the literacy of our audience if we are more specific. Statistical significance does not mean necessarily the same thing as clinical significance. So don't be a cheerleader for the researcher you're interviewing who says, this is important because it's statistically significant. If it didn't make a difference in people's lives, which matters more, statistical significance or the impact on lives? We all must tell stories. But I remind you, the plural of anecdote is not data, okay? And so many times, we can see a very well done story where the journalist worked very hard for balance, maybe quantified harms and benefits, and then totally destroyed the balance of the story with the anecdote, often telling a glowing success story that may not be indicative of what the data showed. I would suggest to you that as you think about whom you're going to interview, don't just turn to your local medical center and say, I need a patient story, because what kind of patient story do you think they're going to provide? The failures? The people who dropped out of a trial? The people who couldn't comply with the medication because of problems? We need to think about the total patient experience, and if you're, again, going to get into this game of telling patient stories, let's make sure they're at least representative and introduce some balance in that storytelling. We talked earlier about the idolatry of the surrogate markers. So tumor shrinkage may not necessarily equate to people living longer and better. So reporting only about surrogate markers or so-called intermediate endpoints, like a test score, may not be the most helpful way, the most complete and meaningful way of conveying benefits. Harms. It isn't sufficient to be vague and just report on common side effects. Let's put a number to them. How common are they? Are they in 4% of patients, or are they in 40% of patients? This is a big one, especially with the introduction of new technologies. Promoters will find sexy, attractive language like minimally invasive to convince us that their idea is better. Well, minimally invasive does not automatically mean safer. Demand the data, compare with existing alternative options, and seek independent perspectives. You can see where some of our 10 criteria start to overlap here. As we're doing this, by the way, you're not rude. If any of you have any questions and want to stop me along the way, please do so. One of the problems we see is when a story fails to describe so-called minor side effects. Well, what is minor to Genevieve might be huge for me. And it almost shows who you're listening to when you write things like that. If you listen to the physician or the researcher, maybe all you'll hear is minor. If you're not plugged into the patient experience, you may not know what the true impact is on the people being treated. Screening tests cause harm. I'm sort of stealing my own thunder from my talk later this afternoon, but all screening tests cause harm, and we'll go into details later. So it is a common journalism practice to overlook the harms of screening tests. I can tell you this, especially with men encouraged to roll up their sleeve for a simple PSA, prostate cancer blood test. Whenever anyone says a simple blood test, run for the hills, because there is no such thing. There are always harms and other factors to think about, and we'll look at many of them later this afternoon. The criterion about the quality of the evidence. So, we talked about the rooster and the sunrise. Don't confuse association with causation and failing to explain the inherent limitations of observational studies. It does not mean these studies are worthless. Let's just give them the credit that they're due and not go beyond that. They cannot prove cause and effect. We often fail to emphasize the limitations of small, short-term studies. The number of stories we see in the US based on 16 people followed for 2 weeks. Let me just transition back to the harms criterion for a minute. How can we establish long-term harms in a 2-week trial? Failure to include the study dropout rate. This one drives me up a wall because this is usually in the study. Even in an abstract, if you learn how to read it, it's usually there. We recruited this many people, but this many people ended up at the end of the study. I wish I had the talk. Someone told me years ago about a famous doctor whose name I also forgot at the Mayo Clinic who talked about a 100% success rate with a drug. And this talk was given to medical students, and he was trying to educate them. And then he explained, we started off with 100 patients, and we lost 99 of them to dropout, and the one who was left in the study had a positive outcome. So it was a 100% success rate. So remember that yourself. Look for it, because dropout rates are incredible, and therein lies maybe the real story. Why did forget the promoting headline about how wonderful this is. Why did 40% of people drop out? That's maybe your story. When we present findings from animal or laboratory experiments without cautioning about the leap into possible human implications. And I wish I could think of the real example. We just reviewed a story last week that did this, made the incredible leap from mice to men without explaining the limitations. Not explaining that abstracts given at conferences don't undergo the same level of rigorous peer review as a paper presented to a journal. So, if this is a scientific conference, and I'm Dr. Schwitzer giving this talk, none of you has ever heard this talk before. I'm probably given 12 to 15 minutes and 10 slides to explain my life's work. None of you has heard it, okay? Deshira happens to be an expert in my field, but she doesn't know about my work yet because I'm just presenting it for the first time, and I'm going very fast because I only have 10 minutes and I have to move on. So you're a good reporter, and you go to Deshira, because you know she's an expert in my field, afterwards, and ask her to comment because you know Health News Review is going to give you an unsatisfactory grade if you don't get an independent source. She doesn't know anything about my work, and she has to react quickly and try to react to something that just went by at 100 miles an hour. This is why we need to, and the number of talks given at scientific conferences that end up never going anywhere or never being published is huge. I mentioned this team from Dartmouth. They happen to be a husband and wife team, Stephen Woloshin and Lisa Schwartz. They published about this a couple of years ago, the pitfalls of reporting on abstracts at scientific meetings. I think their paper was called News Coverage of Scientific Meetings, Too Much Too Soon. And finally, when we present anecdotes, individual personal stories, as if they are evidence of a treatment's harms or benefits, rather than telling them for what they were, a single illustration. Okay, disease mongering requires some explanation. This might be listed in your criteria as number 5, exaggerating the prevalence or seriousness of the condition. And this can range from the amusing to the serious. So I mentioned, do I really need to take a drug for toenail fungus? Do I really need surgery for baldness? Do I really need to worry about dandruff? On up to, are we disease mongering when we promote prostate cancer screening to a population for whom we have no evidence of benefit? And similar with any screening test. Is this disease mongering? The reason that I'm leaving early tomorrow is I'm one of the organizers of a conference in Washington that runs Wednesday through Friday, and it's called Selling Sickness. And indeed, the organizers feel that those who sell sickness are disease mongering. They are making patients out of healthy people. I mean, it can be industry, it can be journalists who make the healthy worry about things that are never going to bother them. So they become sick because of communication efforts. So with that background, you'll often see prevalence estimates that would seem to increase the size of the population that a drug could be intended for. And indeed, then it increases the market size for that drug. So an example, and again, Woloshin and Schwartz of Dartmouth wrote about this. Their example was restless leg syndrome. I mean, how many of you have heard about drugs for restless leg syndrome? Okay. That is a very real condition. I don't know if it's the exact same thing. My wife had it with one of her pregnancies, I know. A very real thing, and for people it bothers, it's a big thing. But the drug company promoting the drugs for this would lead you to believe that everyone in the population is like Elvis Presley with a wild leg. And it's not a harmless drug. It's a drug that was originally developed for Parkinson's disease. So if it has that kind of impact on the brain and neurological system, I'm not sure we want everybody with a little bit of a leg jitter taking it. Question the prevalence estimates. As you choose your patient interviews, is it disease mongering? Is it selling sickness? Is it exaggerating the representation of the patient experience to only use the worst case scenarios? Okay? So if you're reporting on a drug for the common cold, which in most of us will go away on its own, even if you don't treat it, in about a week, but you choose to profile somebody who took a drug because it lasted 10 days or 2 weeks, that's probably not in the norm of normal representative experience. So don't hold such patients up as if they are. Again, third time I've mentioned surrogate markers, but it happens so often. Are we encouraging our audience to focus on numbers, on test scores, on blood values, surrogate markers? So this is a cancer conference, but let me just talk about heart disease for a minute. You know, high blood cholesterol is an important issue. It's an important risk factor for possible heart attack and death from heart attack. But it is not, in and of itself, a sign of how many people are going to die of heart attack or heart disease. So the number itself is not what we should focus on, but what do we know about how many people live worse or die sooner as a result of a condition. The criterion on reporting on alternative options. I understand this is the news industry, so we report on what's new. But I would urge you to report on also what's old. Because as I said before, by definition, if it's been out there, it has a longer track record with more evidence, good or bad, than whatever is being introduced today. So compare the new with the old. Did you discuss the harms and benefits of the new idea with what's already being used? Did you provide some sense of the inevitably larger evidence base for the alternatives already being used? In talking about alternatives, if you're reporting on a surgical approach, a surgery story, please also always think about reporting on, maybe you don't have time, but think about reporting on non-surgical alternatives as well. When reporting on an aggressive intervention, whether it is choosing screening, choosing a drug, choosing a surgical approach, think about reporting on the people who may rationally decide, I'm not going to do anything right now. For some conditions, we can do this. We can watch and wait. Watchful waiting is a term that's sort of gone out of style. Now, many people call it active surveillance. Or Marcia, I'm forgetting one other term for watchful waiting or active surveillance. I'm sorry? Okay, all right, well, we're in the ballpark. But instead of always reporting on the aggressive intervention as one of the options, think about reporting on watching and waiting. And stories about screening tests should mention other screening options similarly, including the option of not being screened. And we'll go into this in a great deal of detail in an hour or two. Okay, the criterion about the novelty of the idea. This is an old saying. If you haven't heard it, it's new to you, but make it an old saying in your mind. In healthcare, we're finding out more all the time. Newer isn't always better. More isn't always better. So make sure you pin down whether this really is new and better. Many new ideas really aren't that novel. So is this the 7th drug for erectile dysfunction that we're going to see advertised on the Super Bowl or during our football games? Is it really that different than what's already out there? Even if a drug is the first one in a new class of drugs, it may not offer any more benefit than drugs that are already widely available. You should know drug companies are very good at promoting their drugs as novel in order to increase their sales. So, are you a journalist or are you working for the drug company? Let's make sure we're giving people the information they really need. This is a good website, clinicaltrials.gov, that is a source of information about other studies that are underway that if you looked here, it may prevent you from falling into the trap of reporting only on the latest and greatest and newest. And you might be able to go on this site and say, whoa, there are 6 other things being researched for the same condition, and maybe those are further on down the track than the one I was about to report on. And of course, another good resource, which we've already talked about, is pubmed.gov, where you can enter a keyword and soon find out whether the new thing really is unique or whether there are other things that you should be reporting on. The availability of an idea. Stories sometimes seem to suggest that something will soon be available, imminently available. Maybe it'll be available within a year, when in fact it might be years away. So I always ask people, whenever anyone you're interviewing makes a prediction about something becoming imminently available, ask them, what is that based on? Your prediction, is your crystal ball very good? Because what are you basing that projection on? That's just what I'm saying with that second bullet. When you're reporting on new devices or new procedures, as you think about availability, it's important to not only think about, is this device approved and on the market, but how many doctors have been trained in how to use it? Think about that. And what's the learning curve to learn a new surgical approach or the implementation of a new device? And if the learning curve is 700 patients, it takes a doctor to do this 700 times before he or she is very good at it, do you really want to be patient number 1 through 699? Well, help your audience think about that. These are very real issues. And when you hear about new approaches, whether they're new devices, new surgical operations, ask how widespread is the approach. That's the point I was making. Do you want to be the first or in that first group, and should anyone in your audience want to be? Maybe they do want to be. Maybe they want to take chances, but you should lay that out for them. The sourcing. This is the big issue we had early today. Who's promoting this? Do they have a conflict of interest? We believe you always need second opinions from independent experts who have no vested interest in the research. Believe me, I heard you this morning. You have a hard enough time finding sources as it is. But if you don't look for an independent source, you may not be doing much more than practicing stenography yourself and simply reporting what a self-promoting person is telling you. Over-enthusiastic claims aren't just made by drug companies or device companies. academic medical centers can be just as guilty. They want to justify their existence. They want to justify their continued research funding. They want to keep their star academic researchers happy. And so it's just something for you to be aware of. I showed you earlier today my CNN example of a leading cancer center in the US that sent out a news release that really didn't have much news in it. So here are some frequent examples of the kinds of conflicts of interest in people that you may not think about, because this is a pretty broad arena. So it can be a trial that's paid for by the drug company. It can be researchers who are either employed by or getting paid by a drug company. It can be a spokesman for a device manufacturer. It can be doctors who are early adapters, who try things early and become true believers. It can be an inventor of a device or of a procedure. All of these people want their product or their idea to look as good as it can. Is that your job, or is that the job of their marketing department? Have I gone through 10? Oh, no, news releases. Did the story rely on a news release? Let's be clear. News releases can be valid and helpful sources of information, but journalism is supposed to independently vet claims, and it is unacceptable to rely on a news release as your only source of information. You might as well just put the promoter of the news release up there in the byline rather than your name. There are many vested interests in healthcare that are trying to influence your readers. We expect journalism to use independent verification and not to rely on news releases or company spokesmen. Dartmouth researchers concluded in a study they did that press releases from academic medical centers often promote research that has uncertain relevance to human health and do not provide key facts or acknowledge important limitations. So, you know, I hope you're aware of this, but I can't, well, we've been doing this now for more than 7 years, and we've only found about 120 stories that seem to be based solely or largely on a news release. But I have to explain, many of those scores are not applicable because we actually have to have a copy of the news release in hand in order to be able to judge if the story said the same thing as the news release. If we don't have the news release, the worst we can give a score is not applicable. So the fact that we've only found 120 stories, to me, is very troubling that we found any that appeared to rely solely or largely on a news release. Yes?
I have found coming from a small country.
I'm not sure it's on. And I'm not sure where the on switch is. Coming from a small country.
When we sometimes get releases from companies or medical releases, there's a problem with advertising. If you don't put it in, they're threatening to pull the plug from your advertising department, and then your owner is going to scream at you because he's lost his advertising dollar. And I battle against that a whole lot. That's a big problem.
It's an awful situation for you to be in. I'm sorry. It's just, and you're not, someone else told me about that before the lunch break. I won't go through a long story, but it's one of the reasons I resigned from CNN. I felt the same thing was happening at CNN. And my decision is one that I wouldn't wish on you. I had to decide if I could look in the mirror, and I couldn't, so I quit. Yes.
But at the same time, I have in the back of my head that I have to be careful because my boss,
Yeah.
my managing editor is going to come at me. Everybody's coming at me, but the bottom line is like all of them.
Yeah.
So I have to be careful. But at the same time, I have in the back of my head that I have to be careful because my boss, my managing editor is going to come at me. Everybody's coming at me, but the bottom line is like all of them. So
Look, I can't wave a magic wand over that. It's an awful situation. My heart goes out to you or anyone that faces that. I mean, it's so idealistic for me to say, then I think you should quit and somebody should care about the kinds of, someone should care about the kind of journalistic principles you have, but that's not reality. I know that. So